the context in which the drug is prescribed may be as important as the drug itself. And as I'm walking across the platform, I fall over something. It turns out to be the prone body of a man. And sure enough, the patient leaves, holding the prescription like it's the Holy Grail. He turns to me, I catch up with him. He's leaning on the fence, looking at the horse. He said, "You see that horse? You see that horse?" I said, "Yes, I see the horse." He said, "I bought that horse for my wife. And she then went to get training on how to ride the horse. And she met this horse trainer, training people to ride the horse, and she ran off with him." Hello and welcome. My name is Dr. Raj Persaud. I'm a consultant doctor and psychiatrist, and I work in private practice in Harley Street in London in the United Kingdom. I want to talk today about ketamine. Ketamine is famous, or perhaps infamous, for being a recreational drug, widely used in the party scene, often very popular with ravers or people who like going to nightclubs. And it's in the news at the moment. It's in the news for various reasons. One is that Matthew Perry, the famous actor in the famous TV series Friends, died with apparent misuse of ketamine. He had various mental health problems. This all is stuff that's out there in the public domain but remains controversial. And it's not clear whether he started using ketamine as a kind of antidepressant. It was prescribed by a doctor who is currently facing trial for maybe misprescribing the drug. And so Matthew Perry's case illustrates a very interesting conundrum around ketamine, which is, given the recent research interest from the scientific community in the idea that it could be a new kind of antidepressant, is ketamine something you should consider taking for your mental health? And that's one of the issues I want to address in this video today. The other reason it's in the news is another famous person died recently, and the death was linked to the possible misuse with ketamine. And this is a drag artist famous on television in the United Kingdom called the Vivienne. So I just want to read you this bit from the BBC News website, which has just been published today, which is why ketamine is so much in the news right now. So the title is "The Vivienne Died 2 days before body found." Drag artist James Lee Williams, better known as the Vivienne, was found dead in the bath by a neighbour after worried friends had struggled to get in touch, an inquest has heard. Williams, the first winner of RuPaul's Drag Race UK in 2019, had likely died at their home in Colton by Backford, near Chester, just under 2 days before their body was discovered on the 5th of January. Cheshire Coroner's Court heard the 32-year-old had privately struggled with addiction to ketamine and had recently relapsed after years of sobriety. Senior Coroner Jacqueline Devonish recorded a conclusion of death by misadventure after the court heard Williams had suffered a cardiac arrest brought on by the drug. This is not that far away from what happened to Matthew Perry. A lot of people don't realize how dangerous this drug is. One of the very serious side effects, if you take too much of it, is it completely destroys your urinary system. Your bladder can pack up, and it can be very serious indeed. So with all the hype over the idea that it could be an antidepressant, it's important to understand that all drugs have side effects, and all drugs, particularly if they have potent effects on the body, possibly could be quite dangerous, which goes back to a point we're going to come to again and again, which is the supervision of the drug is extremely important. And the other reason ketamine is in the news at the moment is because the BBC News website did quite a big piece on it, suggesting that ketamine could be on the verge of being prescribable on the NHS. You could get it free on the NHS. So I did my own little investigation of this and discovered that although there's some private clinics offering it at £6,000 for 4 intravenous infusions and psychotherapy of ketamine, because it's not currently available on the NHS, but the question is, will it become available? Is it just around the corner? I'm going to address that issue. So if you've got £6,000 to spare, then you can get ketamine privately in the United Kingdom. Ketamine was licensed by the FDA, the Food and Drug Administration in the United States, several years ago. So you can get it prescribed by doctors legally for the treatment of depression in the United States. So why is it not available here in the United Kingdom? And that is one of the issues I'm going to address as well. And one of the other things I'm going to discuss is, given antidepressants, which are widely prescribed on the NHS, more traditional antidepressants, not ketamine at the moment, things like Prozac or fluoxetine or paroxetine or Seroxat, these are all quite well-known antidepressants. If these are drugs that are meant to cheer you up, how come no one's dealing them on street corners? But they are dealing ketamine on street corners, which is why this is very interesting that this recreational and party drug might soon be licensed, according to the BBC News website, to be prescribed for your mental health or for a clinical problem like depression, prescribed by doctors on the NHS for free. So I'm going to discuss some of these issues. I'm going to discuss how to help you think about whether you should take an antidepressant or not. And I'm going to discuss some of the common problems over the prescribing of antidepressants and why, in my opinion, they're very poorly prescribed, and that explains why sometimes they don't work. We're going to discuss a neglected issue, which is the setting around the drug, which is the way the drug is prescribed has a lot more to do in the end with its efficaciousness than the simple chemistry of the drug. And I think that's a big misunderstanding in people looking for a magic bullet answer to serious and difficult problems like depression. I'm going to conclude my conversation with you today with a story that I hope you'll find very funny. It's a true story of something that happened to me at medical school many, many years ago, where a GP that I was staying with, a general practitioner, family doctor, and we were meant to stay with them. This is now back in the 1980s, to try and learn what it was like to experience countryside family medical practice or countryside general practice. So my medical school was in the middle of London, University College London, and they had this scheme where you went to stay for a few days with a general practitioner, stay in their house and see what their lives were like. Something very, very funny happened. I learned more about the prescribing of drugs from this doctor. I will obviously disguise details. It happened a long time ago, but it turns out he was having a nervous breakdown and he was drinking too heavily. But despite all these things, he actually taught me more about how to prescribe antidepressants than any other much more eminent and better qualified doctors and professors of medicine since. So I hope that story will amuse you right at the end, but it has got a serious point to it. Let's talk a bit about the background of ketamine. Ketamine is otherwise known as Special K on the streets or in the nightclubs, or Vitamin K or Ket. It was first synthesized back in the early 1960s and was widely used as a drug in anesthesia and also in pain relief. And one of the theories about how it became a street drug is Vietnam veterans who had operations on themselves in the field in the Vietnam War or in a nearby clinic were given ketamine, experienced certain psychedelic experiences, and then tried to pursue getting the drug when they got home back in the USA. So there was something about the Vietnam War that may have led to the widespread use of ketamine. So doctors who were supervising and prescribing this drug, it's also actually used in veterinary medicine as an anesthetic for animals. They noticed that patients who were given this anesthetic agent, sometimes coming out of the anesthesia, would have psychedelic experiences. They would have hallucinations. They would hear and see things. They would have out-of-body experiences, and they would have near-death experiences. So this is how it began to be understood by scientific medicine that ketamine was more than just an anesthetic and a pain-relieving agent, and was actually a drug that could produce psychedelic experiences. And these experiences became the kind of thing that many people pursued or desired, and that's how it became a recreational drug or a street drug. Very interestingly, the setting in which you take ketamine has an influence on your experience of the drug. And the group of doctors who've become more interested in modern times in exploring the use of psychedelic drugs prescribed by scientific doctors, scientific medicine, with an idea that these could have antidepressant properties that we should pay attention to, are using an idea to do with ancient wisdom. Ancient civilizations like the Aztecs used psychedelic drugs for mental health benefits. But very interestingly, these traditional cultures had ceremonies around the use of these psychedelic drugs. So it was the setting and the rituals around them that we now understand may have been very, very important. It's not just the chemistry. And I want to come back to this point, the setting in the clinic, the ritual in the clinic around how antidepressants and drugs that are meant to alter your mind, the way they are prescribed could possibly have a very big impact on the outcome beyond just simply the chemistry. And very interestingly, with ketamine, and one of the reasons it was seen as a kind of middle class or higher class drug in terms of the street view of it, and the view in clubbers and ravers, was that people who were into ketamine were quite careful. These are people who were careful about their drug use, about the setting, and spent a lot of time setting up the circumstances and the room in which they would take ketamine. So there was something a bit OCD, a bit obsessional about the way they set up the setting under which they took the drug. They didn't take the drug in a casual way, though obviously some people do. So we're going to come back to this point again and again. Is there something about the setting, the supervision, the way the drug is taken that actually has as big an impact on simply the chemistry? Now, if you go back to the 60s and the emergence of the interest in psychedelic drugs, things like psilocybin, drugs that you got from mushrooms, and ketamine is part of this group. There was a famous psychologist who actually was at Harvard University called Timothy Leary, largely a forgotten figure now, but very famous back in the 60s and 70s. And he was one of the first academics, because he was at Harvard and had a qualification in psychology. He was an eminent psychologist, you could say. His argument was that we should be examining, using clinical trials and scientific experiments, the use of these psychedelic drugs. I think he was influenced by the idea that there was ancient wisdom attached to it. I, by the way, am a bit skeptical about this whole ancient wisdom thing. I mean, the ancients also bored holes, drilled holes in the heads of the seriously mentally ill to let out the demonic spirits. So, so much for ancient wisdom. I think it can be a little bit overplayed. Anyway, Timothy Leary was an advocate of the use of psychedelic drugs for serious purposes in terms of the treatment of mental health problems. He got into a huge amount of trouble because this was not fashionable back in the day, and he was seen as a slightly disreputable figure, maybe even like a drug pusher, and he lost his job at Harvard as a result. Ironically enough, several decades later, his position is being revisited in clinical trials, in academic journals. Academic departments of medicine and psychiatry in universities all over the world are actively investigating psychedelic drugs like ketamine, with a view that this could be the new wave of antidepressants. So it's a bit of an irony. The poor man lost his job and became vilified. Richard Nixon, President Richard Nixon at the time, once described Timothy Leary as the most dangerous man in the United States. A bit ironic, because probably Richard Nixon was the most dangerous man in the United States. Anyway, another interesting thing about that whole 60s counterculture thing that Timothy Leary was into, and Aldous Huxley, famous writer, wrote this famous book, The Doors of Perception. And the idea there was that these drugs didn't kind of alter your mind so much as produce clarity. They produce transcendence. They helped you see reality as it really was. The Doors of Perception, the Aldous Huxley book, apparently is the book title from which the famous rock band, The Doors, Jim Morrison and The Doors, got the title of their band. So they were said to be the most well-read musicians, by the way, by record producers who produced them. So you got this whole idea around in the 60s, embraced by rock gods like Jim Morrison and so on, that you took psychedelic drugs and it produced clarity. It didn't help you escape reality, which is how maybe we think about it today, but it helped you see reality for what it really was. So another very interesting idea. And could that help with depression and antidepressants. So the latest trials into ketamine and why there's such excitement and interest in it in academic medicine suggest that one dose of an intravenous infusion of ketamine produces remarkable antidepressant effects. People who have been suffering from depression for a long time appear, and they're often recruited to be intractable depressives, right, who haven't responded to other antidepressants. The people who receive ketamine as an intravenous infusion recover almost entirely from their depression. In other words, they achieve a complete cure within a very short period of time, like within an hour or two of the intravenous infusion. No one's seen effects like this with any other antidepressant historically. So that's why there's such incredible excitement now in the scientific community around this drug, ketamine, and why doctors may be prescribing it for your mental health in the future. However, let's just move away from the euphoria to a bit of reality, which is there are scientific evidences as well that these effects wear off pretty quickly. And you've got to keep having the infusion over and over again to maintain the benefit and the effect. So that's problematic. You can get intranasal ketamine, S-ketamine, and that has been licensed by the FDA in the USA, the Food and Drug Administration. So you can get it in the USA for the treatment of depression. So there's intranasal ketamine and there's intravenous ketamine. But you can't actually get those on the NHS still, as far as I can tell. However, there is at least some private clinics here in the UK that are offering you 4 intravenous infusions of ketamine with psychotherapy. Again, notice the setting is important. They're just not just giving you the drug, they're also conducting it in a certain setting. And they're charging you £6,000 for that. 4 intravenous infusions plus psychotherapy, £6,000. You can get it privately. Here in the UK, you can't get it on the NHS, which is why I believe the BBC was slightly irresponsible in raising people's hopes. In a way, they almost became like an advert for that private clinic, selling the stuff at £6,000. So I investigated this myself to find out whether you could get it on the NHS. As far as I can tell, you can't get it on the NHS. But I also contacted my local private pharmacist, where I sometimes prescribe drugs. I hardly ever prescribe drugs, but when I do prescribe, my local pharmacist is the one I go to near Harley Street. And they told me that I could prescribe an intravenous infusion of ketamine, and it would cost about £12. So someone's making a lot of money somewhere, and that's telling you something about the desperation of people who have got an intractable depressive illness and really need alleviation from it, that there's such a big markup on the drug. Ketamine is traditionally a very inexpensive drug, another reason why there's such excitement around it in the scientific community now in psychiatry. It's manufactured perfectly legally in China and India, and it is so cheap. I'm not advocating the drug, by the way, we're going to come to that in a second, but it's so cheap, it's often not adulterated at all. It's one of the least adulterated drugs, because there's no point, it's so cheap, in the clubbing and rave scene. So there is excitement around the fact that you're seeing an antidepressant benefit from ketamine, but it does wear off pretty quickly, and you've got to keep taking the drug. And so people are worried about whether you're going to get habituated or dependent on the drug. However, the excitement is about the fact that with intravenous infusion, many people who've received no benefit from any previous antidepressant are experiencing an almost magical-like cure after just one intravenous infusion and after a very short time. The problem with traditional antidepressants is they can take days or even weeks to start working. Again, that is an overplayed point that family doctors and GPs, general practitioners, here in the United Kingdom prescribe more antidepressants than psychiatrists do, because you hardly ever get a chance on the NHS to see a psychiatrist. So GPs are left holding the baby, as it were. And they all tell patients when they come in to see them and they get the antidepressant that it will take 2 weeks for it to start working. That's not true in my clinical experience. If you've got the right antidepressant with the right patient, within a day or two, they're not going to be cured, but they'll feel some kind of benefit or some kind of effect. So why is it if antidepressants cheer you up, it's not dealt on street corners? You won't get Prozac being dealt to you on a street corner. That's because what antidepressants do is they produce an emotional change, but they don't alleviate depression directly. This is a very important point. The very word antidepressant is really a misnaming. It's really a marketing ploy by the drug companies, because for antidepressants as a word to have any real meaning, antidepressant like antibiotic, you can see the marketing play there, we would have to know what the chemical cause of depression is in the brain, and we don't know that. That's a very important point. One of the reasons you get so many new drugs coming onto the market all the time for many other problems like blood pressure or heart trouble or diabetes is because we understand much better the biological mechanism and underlying those other disorders. We don't know the biological underpinning of depression. So the idea that we're going to create drugs, given we don't know the actual biology and the chemistry, is a bit odd. What has happened over and over again in the history of antidepressant development, unlike other drugs, they've all been accidents. It's been a pure accident that a drug is created normally for something else. You give it to patients, they cheer up as a side effect almost, and people start thinking, aha, we're going to use this as an antidepressant now. I want to emphasize again, the word antidepressant is a misnomer. These drugs do not directly target depression, and they don't directly alleviate depression. What they do is they produce a famous state called emotional numbing. What emotional numbing is, one patient of mine famously described it, is a bit like looking at the world through double glazing, through a very heavily reinforced glass window. So you can still see the world, you can still experience the world, but you do feel removed from the world or buffered from it. And that removal of the stress of being in the world is helpful. But this emotional numbing isn't a magic bullet answer to depression. What it does is it helps you feel a little bit less stressed, a little bit less anxious, and that means you can take this slightly improved mental state and get out of bed and go out into the world and do something about your predicament and about your life. In other words, the treatment of depression or anxiety or any psychiatric disorder doesn't lie in any particular pill. The pill will help you feel a bit better. You need to take that feeling of a bit better and do something with your life. Tackle the problems that are making you feel a bit depressed, like if you're lonely or if you've been left by a husband or a wife, etc., etc. You need to do something about those problems. The drugs will help you do something about the problems, but it's the action plus the drugs that help you get better. The drugs in themselves, no psychiatric drug in itself is ever the pure, total, and only answer to anyone's psychological problems. So that complex explanation about how the drug is meant to work doesn't happen, generally speaking, in the NHS. The GP, the family doctor, the poor doctor's only got 10 minutes in which to try and assess you and do something. So what happens is the patient is left clutching the prescription like it's the Holy Grail with a very poor explanation. And usually they think this is the magic bullet. This will get my depression better. It will not. It will help you get a bit better, but you have to act as well as take the tablet. That's a very important point. And if you can act without taking the tablet, you can often get better from depression without needing to take the tablet, by the way, which is one of the reasons why I hardly ever prescribe. But the major advantage I have in private practice, the patient comes to see me and comes back again and again, and we have an hour together, which is an extraordinarily long time compared to what poor family doctors have in terms of seeing patients. They don't have long enough, so they dish out the prescription. The poor patient leaves believing this is the magic bullet. Now, the other key point coming up is antidepressants need to be properly supervised. The drug is prescribed on the NHS by a GP, and you don't get to see the doctor again for another 6 months. You're left on the drug for 6 months. That is very poor supervision indeed. In private practice, if I prescribe a drug, and I'm reluctant to prescribe, I do prescribe sometimes. By the way, that reluctance goes back to the setting. Because I'm so reluctant and the patient has to really work very hard to prize the drug out of me, and I usually make them go and do stuff before I say, you've got to try this before I'll prescribe the drug, you've got to try that. By the time I prescribe the drug, the fact I've been so reluctant to prescribe it, and the patient's had to work so hard to go and do stuff that I recommend, part of the reason the drug works, in my humble opinion, is all that work that's gone on before I finally release the drug. And my funny story at the end will come back to this point. So there's something about the reluctance to prescribe the drug that generates a psychological effect in the patient, whereby when I finally hand the drug over, they're so grateful to get it. That may be part of the reason, not the only reason, the drug tends to work much more effectively. So we come back to the idea of the context, the setting, and the supervision. So one big tip I want to leave you with is that if you are going to get an antidepressant from a doctor, ask, how is the drug going to be supervised? When do I get to see you again? What happens if there's side effects? Am I able to contact you? If you just get given the drug and are then abandoned for the next few months, this is not the right kind of supervision. In my private practice, when I prescribe a drug, the patient comes back and sees me about 2 or 3 days' time so we can figure out what the effect was, whether there are any side effects, and adjust the dose. Even if they don't want to come back and see me, we can do a phone call. There's very close supervision, particularly at the beginning of the prescribing of the drug, where we monitor side effects, we think hard about the dose, we up the dose, we lower the dose, we modify the dose a lot. In the NHS, general practitioners prescribe one dose, you don't see them again for months. You don't get a chance to discuss side effects, and the dose doesn't get adjusted. That is very poor supervision, and most antidepressants will not work effectively under those conditions. So don't just ask about the drug, don't just ask about the side effects, don't just ask about the chemistry, about how the drug's meant to work. Ask a lot of questions about how the prescribing is going to be supervised. Ask about how the drug is going to be tapered off at the end. How often will you get to see the doctor? Do not accept a drug for any doctor where it is clear there's going to be very little supervision once you've got the drug from that doctor. That, in my opinion, is a very bad sign. Okay, so we now come to the funny story I want to tell. It's a true story, and I think it conveys something about how drugs ought to be prescribed. So I was a medical student back in the day, in the 1980s, at University College London Medical School. They had a scheme in about the 4th or 5th year whereby you could go and stay with a GP for about 2 weeks, I think it was. Now, this is pre the internet, pre even computers, really. That's how old I am. And the way that you selected the GP, there were 124 medical students, was there was a Rolodex, a box full of cards, and each card had the name and address of a GP, and it had the kind of requirements of the GP, like did they have pets, were they vegetarian, did they smoke, whatever. So you could adjust it and decide which GP you were going to stay with, the family doctor you're going to stay with for 2 weeks, and sit at their feet in the clinic and see what it was like to be a country doctor. So I was a very disorganized medical student, and as a result, the all 124 other medical students got to the Rolodex before me and picked out all the best GPs to go and hang out with. So by the time I got to the Rolodex box, there was only one card left. Okay, so this is very important in terms of the story. This guy, this GP with the details, had been rejected by all 124 other medical students. He was the last card left. I was very disorganized, and so I picked up the card. All the cards had gone. The other medical students had picked them up. I was left with the last guy, okay, the guy that everyone else had rejected. And on the card, normally it's full of information about the kind of house you're going to be staying in, the kind of diet the doctors eat, the kind of lifestyle you'd be living. All this card said was, no wimpy lettuce eaters. No wimpy lettuce eaters. So that was a sign that whoever I was going to be staying with was a bit of a character. So anyway, I rang the guy up to sort of set up the details of the train, going to catch a train to go to this rural part of the countryside, and he was going to pick me up. I was a very naive medical student, and you need to understand that for the story to make sense. I didn't really fully understand everything that was going on around me. This GP, family doctor, had been just going through a divorce, and he was clearly having a nervous breakdown of some description. He was drinking very heavily, and it took me a long time to figure all that out. I only figured all that out practically by the time I left. But anyway, I just thought he was a very weird guy. So I rang the guy up, and the phone rang and rang and rang, and then eventually someone picked it up. And the way they picked it up, this is old-fashioned phones now, not like mobile phones. It was like a big scrabbling noise, like he dropped the phone a few times, okay? He was drunk. I didn't even realize that. He said, yeah, sure. And I said, hi, I'm the medical student coming to stay with you next week. Just want to figure out the time I should catch the train and the day. And he said, yeah, okay, right. He said, well, what do you drink? I said, I beg your pardon? He said, what do you drink? I'll get whatever you drink in. And I said, well, I just drink soft drinks. And there was a long silence. And then he said, okay, I'll get a crate of whiskey. Okay, anyway, so I didn't realize he was drunk, but he was drunk. Anyway, so I catch the train. I arrive at the train station. I look up and down the platform. No one is there waiting for me, despite the fact I'd set up this meeting with the guy. So I'm a bit concerned. So I decide to walk off the platform to go to the car park where there's a public payphone. No mobile phones in these days. Okay, this is a long time ago. And as I'm walking across the platform, I fall over something. It turns out to be the prone body of a man who was lying asleep on the platform. And that was the GP, the family doctor I was going to stay with. He was drunk and asleep on the platform floor. Okay, so he woke up when I fell over him, and he recognized who I was and explained that his car was in the car park. So I had to help him to his feet. He was like really drunk. Okay, so I was getting very concerned about him driving. Anyway, so we staggered out with me supporting him. In the car park, which was deserted, there were only two cars. There was a battered old Morris Minor. For the Americans watching, Morris Minor is a very old English brand of car which doesn't exist anymore. Battered old Morris Minor from the 1950s, one part of the car park. In the other part of the car park is a brand spanking new BMW. So I assume he's a family doc, he's got money, his is the BMW. So we struggle over to the BMW. I'm holding this guy up. He's lurching around. He gets the car keys out of his pocket. He drops them a few times, right? And we're scrabbling around on the floor to find the car keys, gets them back up, tries to get into the BMW for about 15 minutes, right? And then, having unable to open the door, this is pre those buttons that open things automatically. This is a long time ago. He steps back from the car and he goes, oh, this is not my car. So I'd taken him to the wrong car. Okay, so we went back to the Morris Minor, and we get in the car. He seems to sober up a bit, which was a relief. And we start driving through the rural countryside of England to his home. At least I thought that was what was going to happen. Anyway, all of a sudden, in the middle of nowhere, just fields all around us, nothing, he stops the car. And then he gets out and he walks across the road, climbs a fence into the next field. And I don't know what's going on. So I get out the car and I rush after him. And he's getting over, crossing fields, climbing fences, crossing fields. We're getting deeper and deeper into the countryside, far away from the road. I have no idea what's going on. I'm getting very alarmed. Eventually, we come to a field, and in the field, there's just a horse standing there, grazing. He turns to me. I catch up with him. He's leaning on the fence, looking at the horse. He said, you see that horse? You see that horse? I said, yes, I see the horse. He said, I bought that horse for my wife. And she then went to get training on how to ride the horse. And she met this horse trainer, training people to ride the horse. And she ran off with him. That's why we're getting divorced. That horse is the reason I'm getting divorced. So then he started to swear at the horse, right, for about half an hour. So I was thinking, oh my God. Now I realized the guy was having a nervous breakdown. Back then I didn't realize that. I was a young, naive medical student. Anyway, we eventually crossed back the fields after he sworn at the horse for a bit. And because the horse caused the marriage breakdown, because the horse trainer, to train his wife to ride the horse, she ran off with the horse trainer. So it was the horse's fault. Anyway, so we get back into the car. We drive into the town. I'm relieved that we're actually going somewhere. We stop at a hotel. I thought, this is a bit odd. I thought we were meant to go back to his place. He parks the car. We go into the hotel. He doesn't explain anything to me, this guy. We go into the basement. I discover we're going to a sauna. Okay, and I'm thinking, what is going on? So we go into the sauna, the locker room. I discover the sauna. I'm a young, naive medical student. It's a naked sauna. Everyone's naked. So he takes all his clothes off. And I'm getting very alarmed. I only just met this guy, and he's drunk. And I'm thinking, what is going on here? Am I going to get assaulted or something? Anyway, he takes his clothes off, so I have to take my clothes off. We're sitting in the sauna naked, and I'm very uncomfortable. I don't do nudity really well in public places. And it's deserted, thank God. Then 2 women come in, also naked. Then it dawns on me what's going on. He's getting divorced. He's lonely. His wife's left him, and he's basically out to try and pick women up. And sure enough, this must be the local pickup joint, right? Because the women come and sit right next to us straight away, which made me very uncomfortable. And they started off the bantering straight away. They said, "So what do you do for a living?" to this GP. Now, I thought that saying that you're a doctor is not bad, as a opening gambit with women. Instead, blow me down. He didn't say he was a doctor. The women said, "So what do you do for a living?" He said, "I'm a test pilot for fighter jets." Thinking, oh my God, what is this? Anyway, so he banters away with the women. Eventually, we leave the sauna and we get home, thank God. He has a very heavy night drinking. We wake up the next morning and he is very hungover. And I'm thinking, this is going to be interesting because we got an outpatient clinic this morning. Anyway, he's nursing a terrible headache. He's nursing a cup of coffee. He keeps asking me to bring him coffee. We get to the surgery at long last. I'm sitting in the clinic with him. The first patient walks in, okay? And the doctor looks like he's asleep. He's got his eyes closed. And he's breathing very heavily. And I'm getting alarmed about what's going to happen in the consultation. So anyway, he sort of wakes up and he says to the patient, "So what's the problem?" The patient relates a set of symptoms. And then there's a long silence, and he looks like he's fallen asleep again, the doctor. But then he leans forward. He goes, "Look," he said, "I don't normally do this," he said, "but on this occasion, I'm going to prescribe a drug I hardly ever prescribe because it's so powerful and it's so expensive that the NHS don't normally allow me to prescribe it. But on this occasion, I'm going to make an exception and I will prescribe this drug." Anyway, he went on and on and on about how he's not normally allowed to prescribe it. He's going to make an exception. And it was such a big, build up to the prescribing of the drug. The patient left clutching the prescription like it was the Holy Grail. That patient felt incredibly special to have been made an exception of and have that drug. Patient number 2 comes in. This is very important for what happens next. Completely different set of symptoms. The GP listens carefully, long silence. I think he's fallen asleep again, and he suddenly wakes up, and then he goes, "I don't normally do this." And then he does the whole spiel all over again about how he hardly ever prescribes this drug, almost word for word. And sure enough, the patient leaves, holding the prescription like it's the Holy Grail. Anyway, later on that day in the lunch break, I was out the street, and the local pharmacist, I was in the pharmacy, the local pharmacist came up to me and said, "Oh, are you the medical student with the doctor?" And I said, "Yes." He said, "Will you get him to stop prescribing Penbritain, an old form of penicillin? Because they don't make it anymore, and it's getting very difficult to get hold of." He was basically dishing out this very old drug, whatever symptoms the patients had. But here's the key take-home lesson. This guy gave the drug a really big build-up. He really sold the drug before he prescribed it. And I believe that I learned a very valuable lesson. That's one of the reasons the patients adored him and thought he was a great doctor. Whether he was or not, it's another matter. Because the build-up meant they all felt special. They all felt unique. And I bet you that drug worked every single time, even though it probably wasn't even particularly relevant. So, the context in which the drug is prescribed may be as important as the drug itself. And the ancient wisdom understood that, hence the rituals and ceremony that accompanied the prescribing of these psychedelic drugs hundreds or thousands of years ago. And we've forgotten that in modern technological medicine, where we believe it's the molecular structure of the drug that's doing the real action. Whereas I believe the ritual and the ceremony around the prescribing of the drug, I'm not saying the chemistry is not important, but I believe the rest of that is important as well. Well, I hope you found this useful and informative, and we've been using ketamine as an example to think about antidepressants. Thank you very much indeed for listening.